This is my coagulation case study. A 14-year-old female went to the emergency room with her mother and grandmother with a chief complaint of heavy menstrual bleeding. The hospital staff also noted she had petechia on her abdomen, arms, and thighs, and she reported no history of aspirin or NSAID use. So here are her lab results from the hospital. Her red blood cells, hemoglobin, hematocrit, and platelet were all decreased. Everything else was in normal range. So a little patient history. When she was 4 years old, she was diagnosed with ITP. At the time, it was unclear what treatment she had received for it. They diagnosed her with this based on frequent nosebleeds, some petechia, and occasional bruising. Otherwise, she reported she was fine until menstruation. The patient is also an only child. So some family history. Both of her parents immigrated from Iran when they were infants. The grandmother stated that the mother and father were related, both being from the same small village in Iran. The grandmother also said that several of her cousins and uncle experienced frequent nosebleeds. So the ER physician noted a normal PT, APTT, and a slightly decreased platelet count, but he didn't feel that those lab results were extensive enough for the amount of petechia and the amount of bleeding she had. The manual differential showed that things were mostly normal. She had some slight polychromasia and anisocytosis. Her platelets were slightly decreased, and she also had giant platelets. She was then referred to a hematologist for further workup. And here is a slide. It shows that there are a couple of giant platelets on there. So ITP that she was originally diagnosed with, it's an autoimmune bleeding disorder. The immune system makes antiplatelet antibodies which cause destruction to the platelets. This can happen following a viral infection or live vaccinations. Typically in children, it's acute and self-limiting, and it resolves in several weeks. In some cases, it progresses and it may become chronic. So treatment for ITP, originally she was treated with immunoglobulins with no positive results. Then they gave her HLA matched platelets, and she did have some slight improvement. After that point, the patient stopped seeing the hematologist, and she and her family described her condition as improved. However, though, she was still experiencing the nosebleeds. Bernard-Soulier syndrome is a rare inherited disorder of blood clotting. Typically, it's autosomal recessive. The patient will have large platelets, a low platelet count. They will bruise easily, and it'll be excessive bruising. They'll also have nosebleeds, and in women, they'll have a heavy menstrual flow. BSS was first described in 1948 as a bleeding disorder with prolonged bleeding time and giant platelets. It is caused by platelet glycoprotein deficiencies. It's rare. It's estimated to only affect 1 in 1 million. It's typically more common in families where the parents are related. A lot of the times it is diagnosed at a young age, but if it's autosomal dominant, it can be less severe, and then in that case, diagnosed later in the life. So in BSS, they're missing an essential protein, which is the GP1B. The GP1B is composed of 4 protein subunits, and 3 of those 4 subunits have mutations. The GP1B complex sticks out of the platelet surface and binds to another protein, and that protein is the von Willebrand factor. So if that protein is absent or abnormal, it cannot bind to begin the clotting process. So platelet function analyzers It aspirates saturated blood through a membrane to induce adhesion platelet plug formation. So first the test is performed with collagen and epinephrine membrane. If the closure time is normal, then they consider the platelet function normal. If the closure time is increased, they repeat the test again, this time using a collagen and ADP membrane. If it's prolonged with both the epinephrine and the ADP, or increased with the epinephrine and normal with the ADP, then it indicates an aspirin-induced platelet disorder. But if it's prolonged with both of them, then the defect is not aspirin-related. So the patient in this case, her times were increased with both of them. So this is a diagram that just shows how that test works. So they insert the blood on the left. It's pulled up by capillary action to go through the membrane with the collagen and epinephrine or the ADP, and then they can see there whether or not that platelet plug forms. The Ristocetin-induced platelet aggregation test, it's measured by aggregation of platelets in platelet-rich plasma by adding ristocetin in 2 different concentrations. So the agglutination requires both the von Willebrand factor and GP1B/9. So if the RIPA is decreased from the von Willebrand factor, it can be corrected with the addition of normal plasma. But in Bernard-Soulier syndrome, that normal plasma will not correct it. So our patient's results with some more coagulation studies, they found that her PT and APTT are normal. So a disorder of primary hematostasis is suspected. Her platelet count is decreased. She has giant platelets. Both the collagen with the epinephrine and the ADP were abnormal. She had abnormal aggregation with the ristocetin, and then she also has reductions in the CD42A and the CD42B. All of these test results led them to a diagnosis of Bernard-Soulier syndrome. So misdiagnosis in BSS, it's rare, so oftentimes it is mistaken for ITP, which is more common than Bernard-Soulier syndrome. A lot of times these patients are treated with immunoglobulins, steroids, IV administered vitamin D and other drugs, and in some severe cases, splenectomies have also been recorded. So some clues that it is Bernard-Soulier syndrome and not ITP is that childhood ITP that doesn't resolve or respond to treatments. Some of the family history of whether or not the parents are related, family history of bleeding, and platelet counts that are low but not low enough to explain the amount of bleeding the patient is experiencing. So treatment for Bernard-Soulier syndrome, it focuses on the prophylactic treatment before procedures or after injuries. The patients are instructed not to take NSAIDs. Antifibrinolytic therapy is administered during bleeding episodes. Platelet transfusions before surgery or if other options have failed the patient. In several cases, or in severe cases, they will do stem cell transplant, and in the future, it's possible that they'll be a candidate for gene therapy.